1, 2,
and female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep your heart again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people check? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Alright guys, so we're going to be coming up on fluid and electrolyte balance. Now this right here is known to be one of the harder concepts in nursing, or at least in nursing school, which is being able to look at a blood gas strip and being able to determine if you're in metabolic acidosis or respiratory acidosis, or maybe even metabolic alkalosis or respiratory alkalosis. Again, it is known to be one of the harder concepts to understand because you're tracking 3 or 4 different things. You have your own labs that you have to be kind of paying attention to. Not only do you have your SpO2, but now you're getting into PaO2, which is going to be your partial pressure O2. And then you have this FiO2, which will be strictly ventilator stuff. I'm in the ER. I don't speak ventilator. Respiratory speaks ventilator for me. But blood gas is, again, one of the more complicated topics to kind of conceptually understand it. Like I said, it's just because you're having to track multiple things at the same time. And then when this is out of balance, what's this doing? And then you have fully compensated or partially compensated, blood gas and stuff like that. So I'm a huge proponent of collaborating with other people, or at least passing the bill off to someone else who does a better job at explaining something better than me. And Nurse Mike over at Simple Nursing does the best job at explaining blood gas. Hands down, the easiest way to understand and conceptualize the blood gas ABGs when you're talking about compensated, uncompensated, fully compensated, partially compensated. You're looking at your pH, your bicarb, and your O2 or your CO2. All of that stuff, Nurse Mike does the best job at explaining it. He has the best way of being able to write it down on paper and being able to tell within a few seconds if you're in respiratory or metabolic acidosis, alkalosis, if you're compensated or partially compensated or fully compensated. So he does the best. So by all means, go to YouTube or get a subscription to his service and look at his blood gas material. Hands down, the absolute best out there at explaining and being able to understand blood gas and the blood gas values. This is just a little intro to that. So again, Nurse Mike at simplenursing.com. I'm not affiliated with the guy by any means, or he's not paying me to say that. I just, real recognizes real, right? So homeboy is up there. He's got the best blood gas videos on the market. By all means, I believe he has it free on YouTube, or you can purchase his subscription and listen to it there or watch it there. Absolutely amazing. So go check his stuff out on YouTube or his website.
When you're standing outside a patient's room in the ICU, there's always this expectation of precision. Like, it's almost like engineering.
Yeah, right. Like it's a math problem.
Exactly. If someone breaks their femur, the X-ray shows that jagged white line, and the orthopedic surgeon just points at the screen and says, there it is. That's the problem. Let's put a rod in it.
Right. It's very binary. It's structural. And I mean, human beings love structural problems because they are visible. We really like things to be categorized, boxed up, and, definitively diagnosed before we actually intervene.
But then you cross the threshold into critical care, specifically when you're dealing with fluid, electrolyte, and acid-base imbalances. And suddenly that X-ray machine is, well, it's completely useless. You are no longer dealing with a structural problem.
No, not at all. You were dealing with a chemical war zone.
A chemical war zone, yeah. We're looking at a diagnostic landscape that is, honestly, it's murky. It's totally invisible to the naked eye.
It is the absolute definition of diagnostic muddy waters. And, that is exactly the environment we were wading into today, because in the intensive care unit, the numbers on a lab report your sodium of 120, your potassium of 6.5, your pH of 7.15. They are never just static data points. They are a real-time story of a body that is either desperately compensating for a massive physiological insult or one that is actively failing right in front of you.
Which brings us to our mission for this deep dive into the source material. We are taking a definitive guide on fluid and electrolytes, and we are completely throwing out the academic fluff.
Absolutely.
Like, we aren't going to define basic terminology that you already know. You know what tachycardia is. You know what MAP is. Instead, we are aggressively applying the 80-20 rule here.
Right, the Pareto principle.
Exactly. We are focusing on the precise pathophysiological mechanisms, the clinical reasoning, and the bedside decision-making skills that separate a novice from a truly seasoned critical care nurse.
Because to think like an intensivist, you have to connect the cellular dots. It is always a cascade. Like, there is a trigger, which causes a physiologic change, which leads to compensation, then decompensation, and finally, the clinical findings you actually see at the bedside.
Yeah.
You have to understand the why behind the what, or you will always be, 3 steps behind the patient's deterioration.
Let's ground this in an analogy.
Yeah.
Because as I was going through the source material, I kept picturing the body's fluid and electrolyte system as this highly secure, incredibly complex, high-tech aquarium.
I like that.
Right. We weren't just talking about a bowl of water. We were talking about an ecosystem where the absolute slightest shift in the pH of the water or the salinity or, the electrical charge of the filtration system means imminent death for everything inside.
I think that's the perfect way to visualize it. And if we take that aquarium analogy to its logical conclusion, as an ICU nurse or an intensivist, your job isn't just to look at the fish and note that they seem sluggish today.
No, of course not.
Your job is to monitor the invisible chemistry of the water. You have to predict when the tank's filtration system is going to fail based on subtle trends. And you have to intervene with the precise chemical fix before irreversible cellular injury actually occurs.
So before we can even begin to understand the specific chemicals like the electrolytes, the salt, the electrical charge in the water, we have to understand the physics of the water itself.
The foundation.
Right. Let's look at fluid dynamics and volume imbalances. When we are visualizing the movement of water between our blood vessels, the intravascular space, and our tissues, the interstitial space, what forces are actually at play here? Because the old nursing school analogy of a leaky garden hose and a sponge always felt a bit, simplistic to me.
Oh, it is simplistic. It really doesn't capture the sheer dynamic power of what's happening at the capillary level. I mean, instead of a garden hose, I want you to picture the intravascular space as a high-pressure municipal water main forcing fluid through a semi-permeable membrane.
Okay, a water main.
Yeah, that is your hydrostatic pressure. It is the physical mechanical force of the blood being pumped by the left ventricle of the heart. It's physically pushing fluid out of the capillary and into the tissue spaces to, deliver oxygen and nutrients.
Right. But if that was the only force, all the water would just be pushed out into the tissues, our blood vessels would instantly collapse, our blood pressure would drop to 0, and we'd swell up like massive water balloons.
Exactly.
So there has to be a counterforce pulling it back in.
There is. And that counterforce isn't just a passive sponge, it is oncotic pressure, which is also called colloidal osmotic pressure. I want you to think of oncotic pressure like the gravitational pull of massive planets.
Oh, wow. Planets.
Yeah, hear me out. Inside your blood vessels, you have these massive plasma proteins, primarily albumin. They are too large to easily pass through the capillary walls, so they stay inside the vessel and they exert this powerful osmotic gravitational pull. They literally drag water back into the bloodstream from the tissues.
So it's a constant tug of war. The heart's mechanical pump pushes the fluid out, and the gravitational pull of the albumin pulls it back in.
Precisely. And when those pressures get out of balance, that's when you get dangerous fluid shifts. Like, first spacing is normal. The fluid is in the blood vessels and the cells where it belongs.
Right.
Second spacing is an abnormal accumulation in the interstitial space. We see that as edema. The hydrostatic pressure overwhelmed the oncotic pull, maybe because of heart failure, and fluid leaked into the tissues of the legs or the lungs.
But then there's third spacing, which is what really keeps intensivists awake at night, because visually the patient might look incredibly swollen, but hemodynamically they're crashing.
Third spacing is a profound physiological betrayal.
It's a betrayal. That's a good way to put it.
It is. The fluid gets trapped in non-functional areas where it is incredibly difficult to get it back into the blood vessels. Think of a patient with massive ascites in the abdomen from liver failure, or the systemic capillary leak you see in severe burns, sepsis, or acute pancreatitis.
Right, the inflammatory response.
Exactly. The inflammatory cascade destroys the capillary integrity. The fluid rushes out of the vascular space into the tissues or body cavities. The fluid is technically still inside the body, but it is completely useless to the circulatory system.
So you have a patient who might weigh 20 pounds more than they did yesterday because of all the fluid they've retained.
Yeah.
They look like the Michelin Man, but their intravascular space, their actual blood vessels, are completely dry.
Completely dry, yes.
They are in hypovolemic shock while simultaneously being massively edematous.
Exactly. And if you just look at them visually and say, oh, they're fluid overloaded, let's give them a diuretic, you will kill them.
Wow.
You will drain whatever tiny amount of volume is left in their blood vessels. Their blood pressure will bottom out and they will go into cardiac arrest. You have to treat the intravascular volume deficit first, usually with volume expanders or colloids like albumin.
To increase that gravitational pull you mentioned.
Right, to increase that pull and drag the fluid back into the vessels before you even think about diuresis.
That brings us perfectly to the clinical breakdown of hypovolemia versus hypervolemia, fluid volume deficit versus fluid volume excess. Let's talk about the assessment. Imagine you are at the bedside. The patient has severe volume loss. Maybe they're bleeding out internally or they have severe prolonged diarrhea. The tank is emptying. What is the absolute first physiological alarm bell that goes off?
The very first sign is almost always a rising heart rate, tachycardia.
Not the blood pressure.
No, blood pressure dropping is a late sign. The baroreceptors in the aortic arch and carotid sinus sense the drop in blood volume first. They send a panic signal to the medulla, which triggers a massive sympathetic nervous system response. Epinephrine and norepinephrine are dumped into the system. The heart basically says, okay, we have less blood to work with, so I have to pump what's left much, much faster to ensure the brain and the kidneys still get oxygen.
So the rising heart rate is the compensation phase. The body is fighting back.
Yeah.
But what happens if the volume loss continues? Like, when does the compensation fail?
It fails when the heart is beating so fast that it doesn't have time to actually fill with blood during diastole, or when there simply isn't enough volume left to generate pressure. That is when you see the late, terrifying sign, a plummeting blood pressure, specifically a dropping mean arterial pressure, or MAP.
Right, the MAP.
Once the MAP drops below 65 millimeters mercury, you are no longer adequately perfusing your vital organs. The kidneys shut down to conserve water, which is why urine output drops to near zero. And as the brain becomes hypoxic, the patient goes from anxious to confused to, eventually, lethargic.
Wait, I want to pause on the assessment piece because the source material points out a huge trap here regarding assessing fluid volume deficit, especially in the elderly. Skin turgor, we're all taught to pinch the skin on the back of the hand or the clavicle to see if it tense up, right?
Yes, the classic bedside trap. Do not trust skin turgor in the elderly.
Really? Never.
Never. As human beings age, our skin naturally loses collagen and tissue elasticity. An 80-year-old patient's skin might tent and stay tented even if they are perfectly 100% hydrated. It is a completely unreliable metric for that population.
So if skin turgor is a lie for older adults, what is the absolute gold standard for assessing volume status? How do we know if our interventions are actually working?
Daily weights. It is the single most accurate, non-invasive measure of volume status. The math is incredibly rigid. 1 kilogram of acute weight gain or loss, that's 2.2 pounds, equals exactly 1 liter of fluid.
Right.
If a heart failure patient gains 3 kilograms over a weekend, they didn't eat 6 pounds of fat. They retained 3 liters of water. But to make this data usable, the nurse has to be militant about it.
Militant how?
You weigh them at the same time every day, usually at 0600 before breakfast. They have to be wearing the exact same amount of clothing on the exact same calibrated scale after they've voided. Otherwise, the data is garbage.
Let's talk about the diagnostics, because the labs tell a very specific story here. How did the kidneys signal what's going on with the fluid?
You look at the urine-specific gravity, which measures the concentration of particles in the urine. Normal is around 1.010 to 1.025. If the patient has a fluid deficit, hypovolemia, the kidneys are in panic mode. They release antidiuretic hormone and aldosterone to aggressively hold on to every single drop of water and sodium they can.
So they stop making urine.
Pretty much. And as a result, the urine they do produce is incredibly dark, concentrated, and heavy. The specific gravity shoots up greater than 1.025.
And on the flip side, in hypervolemia, the fluid overload state.
The exact opposite. The intravascular space is overfilled. The hydrostatic pressure is so high it's forcing fluid into the lungs, causing crackles, and backing up into the venous system, causing jugular venous distension, or JVD.
So the heart is stretching.
Exactly. The heart stretches, releasing brain natriuretic peptide, or BNP, which tells the kidneys, dump water immediately. So the kidneys excrete massive amounts of pale, dilute water, and the urine-specific gravity drops below 1.010.
You'll also see the hematocrit and the BUN blood urea nitrogen rise in hypovolemia, right? But not because the patient is suddenly producing more red blood cells or urea. It's an illusion of concentration.
Exactly. It's hemoconcentration. Think of it like this. If you have a glass of water with a tablespoon of salt in it, and you boil away half the water that's left is twice as salty. The amount of salt didn't change, the volume of water did. In hypovolemia, there is less plasma diluting the solid particles in the blood, so the hematocrit and BUN percentages artificially spike. When you rehydrate them, those numbers will magically normalize.
So synthesizing this into priority nursing actions, the ADPIA framework, the patient is getting worse. If you see that heart rate creeping up while the blood pressure is creeping down, right? That widening gap between the two is the hallmark of impending shock.
Yes. Rising heart rate, falling blood pressure, a sudden halt in urine output, and a change in mentation. If you see those trends in a hypovolemic patient, you don't just note it in the chart, you escalate. You anticipate orders for rapid isotonic IV fluid resuscitation, you ensure you have large bore IV access, and you implement strict fall precautions because they are at extreme risk for orthostatic hypotension.
And for the hypervolemic patient, the one with bounding pulses and crackles up to their collarbones.
You are sitting them straight up in bed to help them breathe, first of all, applying oxygen, then restricting their sodium and free water intake, and preparing to administer potent loop diuretics like furosemide to force the kidneys to dump the excess volume. You also have to meticulously protect their edematous skin.
Because it's fragile.
Exactly. Tissue that is swollen with fluid is incredibly fragile and prone to rapid breakdown and pressure injuries.
Okay, so to bring the fluid foundation together for the listener standing at the bedside, let's do the, if you remember, only 5 things.
Perfect. Number 1, the core patho. Hydrostatic pressure pushes fluid out, oncotic pressure pulls it in. Number 2, key assessment. Daily weights are the most accurate volume measure. Number 3, dangerous complication. Hypovolemic shock or pulmonary edema. Number 4, priority action. Trend the vital signs, specifically HR and BP and daily weights. And number 5, important treatment. Treat the underlying cause and use appropriate IV fluids or diuretics.
And if we want a one-sentence clinical picture?
Hypovolemia looks like a dry, tachycardic, hypotensive patient. Hypervolemia looks like a wet, bounding, breathless patient.
So if you see a rapid weight drop combined with a rising heart rate, your intensivist brain immediately recognizes hypovolemia, and you are reaching for isotonic IV fluids to save the tank.
Perfectly summarized. That is the foundational knowledge required to even begin discussing the chemicals in the water.
Which brings us to our next major physiological hurdle. Let's move from the water in our aquarium to the primary electrolyte that actually controls where that water goes. Sodium, the neurologic gatekeeper. Now, looking at the sources, it emphasizes heavily that sodium is an extracellular ion. It lives outside the cells, in the blood, and the interstitial fluid.
It does, and the 80-20 golden rule here, the single concept that governs everything about sodium, is incredibly simple. Sodium equals water, and sodium equals brain.
Sodium equals brain. I want to dig into that because when we think of sodium, we just think of salt, like table salt. But you're saying it's essentially a water problem in disguise.
Almost always. Sodium imbalances are rarely a problem with the actual amount of sodium in the body. They are a problem with the amount of free water diluting or concentrating that sodium. You either have too much free water, which dilutes the sodium, causing hyponatremia, or you have a profound deficit of free water, which concentrates the sodium, causing hypernatremia. And the organ that suffers the catastrophic consequences of these water shifts is the human brain.
Let's break down the pathophysiology of why the brain is so vulnerable. Let's start with hypernatremia, high serum sodium, over 145 milliequivalents per liter. What is happening at the cellular level?
Hypernatremia is a water deficit. The extracellular fluid, the blood, becomes severely hyperosmolar. It is too salty. Because of the laws of osmosis, water always wants to move from an area of low concentration to an area of high concentration to achieve balance.
Right.
So that highly concentrated salty blood acts like a massive osmotic magnet. It literally sucks water out of the intracellular space to try and dilute the blood.
The result being that the cells dehydrate and shrink.
Exactly. Now, if the muscle cells in your biceps shrink a little bit, it's not a lethal issue. But if the neurons in your brain shrink, they physically pull away from the cranial vault. They pull away from the meninges. This causes the bridging veins in the brain to stretch and tear, leading to subarachnoid or subdural hemorrhages. The patient becomes agitated, delirious, starts seizing, and rapidly progresses to a coma.
And hyponatremia, low sodium, under 136.
It's the exact reverse scenario. Hypernatremia is a free water excess. The blood becomes hyposmolar or dangerously dilute. The fluid in the bloodstream is now less concentrated than the fluid inside the cells. So osmosis shifts into reverse. The water rushes out of the bloodstream and into the cells. The result, the cells swell up like water balloons.
And here is where the rigid anatomy of the skull becomes a death trap.
Precisely. The skull is a closed, rigid box made of bone. It has a fixed volume. It contains brain tissue, blood, and cerebrospinal fluid. There is zero room for expansion.
None.
None at all. When the brain cells begin to swell due to hyponatremia, they instantly run out of room. They press outward against the unyielding bone of the skull. The intracranial pressure skyrockets. The patient develops a severe headache, profound lethargy, and confusion.
And if that swelling isn't stopped, like if we don't intervene,
the brain has only one exit route, the foramen magnum, the hole at the base of the skull where the spinal cord exits. The swollen brain tissue will literally herniate down through that hole, crushing the brainstem. The brainstem controls your breathing and your heart rate. If it herniates, the patient dies instantly.
that is terrifying. So the rigid box makes it a zero-error environment for the nurse. The moment you see an abnormal sodium level, you aren't just looking at a lab value. You are looking at a ticking neurological time bomb. What are the priority treatments? Let's start with the shrunken cells and hypernatremia.
The treatment for hypernatremia is to carefully replace the missing free water. If they are severely hypovolemic, you might start with isotonic fluids just to stabilize their blood pressure. But to fix the actual cellular dehydration, you will anticipate orders for hypotonic IV fluids like 0.45% half-normal saline or D5W. These fluids are less concentrated than the blood, so they will gently push water back into the shrunken cells.
And for hyponatremia, the dangerously swollen brain cells.
The first-line treatment for mild hyponatremia is remarkably simple. It's fluid restriction. You just stop giving them free water. You lock the water pitcher away. This gives the kidneys time to catch up and excrete the excess water on their own. We might also use loop diuretics to help dump the volume.
But what if it's severe? What if the sodium is like 118 and the patient is actively having a seizure because their brain is swelling? Fluid restriction isn't going to work fast enough.
No, it won't. In that emergency scenario, we use small, highly controlled amounts of 3% hypertonic saline. This is a remarkably dangerous fluid. It is incredibly salty. When you infuse 3% saline to the bloodstream, it instantly spikes the intravascular osmolality, acting like a supermagnet to aggressively rip water back out of the swollen brain cells. That shrinks them down to relieve the intracranial pressure. We can also use specific medications called vasopressor receptor antagonists, drugs like conivaptan or tolvaptan.
Oh, how do those work? I haven't heard of those as much.
They block antidiuretic hormone at the receptor level in the kidneys. They essentially force the kidneys to excrete massive amounts of pure free water without losing any sodium. It's a very elegant pharmacological fix.
But here's where the source material flashes massive, bold warning signs. The ICU pearls and the exam traps. Because the most dangerous thing about sodium isn't just the imbalance itself, it's actually the medical team trying to fix it.
Yes. This is one of the most critical safety alerts in all of critical care. The greatest threat to the patient is the nurse or the physician correcting the sodium level too quickly. If a patient has been chronically hyponatremic, their brain cells have adapted to that swollen state over days.
Right.
If you come in with your 3% hypertonic saline and you rapidly increase their sodium level, pulling all that water out of the brain cells in a matter of hours, you will cause a devastating iatrogenic condition called osmotic demyelination syndrome, or ODS.
I read about ODS. It used to be called central pontine myelinolysis. What exactly is happening to the nerves there?
The rapid osmotic shift physically shears the protective myelin sheath off the nerve fibers in the brainstem, specifically in the pons. It destroys the insulation of the nerves. And the tragedy is the damage is permanent and irreversible.
And the clinical presentation of ODS, like what does the patient experience?
It results in locked-in syndrome.
Yes.
The patient is completely awake, fully conscious, entirely aware of their surroundings, but they are paralyzed from the eyes down. They cannot move, they cannot speak, they cannot swallow, they cannot breathe on their own. They are trapped inside their own body forever because the medical team corrected a lab value too fast.
Wow. So to avoid creating that absolute nightmare, what are the hard, non-negotiable numbers? What are the hold parameters for correcting sodium?
The math is etched in stone. For hypernatremia, you must never decrease the sodium by more than 8 to 15 milliequivalents per liter in an 8-hour period. And for hypernatremia, you absolutely do not increase it by more than 10 to 12 milliequivalents in a full 24-hour period. You draw serum sodium levels every 2 to 4 hours. If the level is rising too fast, you stop the hypertonic infusion immediately. Slow and steady is the only way to save the brain.
So if you are at the bedside, deterioration looks like any change in mental status. If your patient goes from slightly irritable to confused, or if they develop a sudden tremor or have a seizure, they are decompensating.
Exactly. The absolute priority nursing action, the very second you see a critically abnormal sodium level, whether high or low, is to immediately initiate seizure precautions. You pad the bed rails, you ensure suction and a bag valve mask are functional and at the bedside, and you prepare for a neurological emergency.
Okay, pulling the sodium insides together for our 5 things.
Let's do it. Number 1, core patho. Sodium imbalances cause water to shift in or out of brain cells. Number 2, key assessment. Changes in mental status, confusion, seizures. Number 3, dangerous complication. Brain herniation from hyponatremia or osmotic demyelination from correcting it too fast. Number 4, priority action. Initiate seizure precautions and strict IO. And number 5, important treatment. Slow, calculated correction of the water imbalance.
So the one-sentence clinical picture is an altered, confused patient who either has too much free water making them dilute or too little making them concentrated.
Right. And if you see new onset confusion and a sodium of 120, think cellular swelling and seizure risk, and do initiate seizure precautions and anticipate fluid restriction or 3% saline. You protect the brain while you fix the water.
Beautifully stated. The brain is the victim of the water's mistakes. Let's transition now. We've seen how sodium forces water to rush in and out of the cells, threatening the structural integrity of the brain. But what happens when the actual electrical charge across that cell membrane gets disrupted? Let's move from the brain to the heart. Potassium, the cardiac conductor. Now, sodium lived outside the cell, but the sources emphasize that 98% of all the potassium in the human body lives inside the cell.
Yes, it is the major intracellular cation, and that absolute boundary between the high potassium inside the cell and the high sodium outside the cell is maintained by the hardest working protein in the body, the sodium-potassium pump. This pump constantly uses ATP to actively push 3 sodium ions out of the cell and pull 2 potassium ions back in, working against the concentration gradient.
And because it's pushing 3 positive charges out, but only taking 2 positive charges in, it creates a net negative electrical charge inside the cell.
Exactly. It establishes the resting membrane potential. It primes the cell like a loaded spring, ready to fire an action potential. And that is why the 80-20 overview for potassium is so critical. If sodium dictates the brain, potassium dictates the heart. Potassium controls the electrical conduction of nerve and muscle cells.
And because 98% of it is hidden inside the cells, the amount actually floating around in the blood, the extracellular fluid, is tiny. Normal serum potassium is just 3.5 to 5.0 milliequivalents per liter.
It is a razor-thin margin, which means even a microscopic shift of potassium out of the cells and into the blood causes massive, life-threatening cardiac conduction issues. A potassium level of 7.0 might not sound like a huge jump from 5.0, but electrically, it is a catastrophic avalanche.
Let's use that intensivist thinking to explore the pathophysiology here, because this is where the cellular mechanics get really fascinating. The sources state that severe acidosis causes hyperkalemia. Why? How does blood pH alter the potassium level?
This is a brilliant, albeit dangerous, compensatory mechanism. In a state of metabolic acidosis, say the patient is in diabetic ketoacidosis or severe sepsis, you have a massive accumulation of hydrogen ions in the blood. Hydrogen is an acid. The blood pH drops precipitously. The body panics and tries to buffer this acidic blood by hiding the acid. It literally shoves the excess hydrogen ions inside the cells to get them out of the bloodstream.
But the cell can't just take on an infinite amount of positive charge without throwing off its own electrical balance, right?
Right. To maintain electrical neutrality, for every positively charged hydrogen ion the cell takes in, it has to kick a positively charged ion out. And the most abundant positive ion inside the cell is potassium. So the cell takes in hydrogen to fix the acid problem, kicks out potassium into the blood, and suddenly your serum potassium level spikes.
Wow.
The body successfully buffered the acid, but in doing so, it created a lethal hyperkalemia that is going to stop the heart.
That is a phenomenal example of a compensatory mechanism becoming the fatal complication.
Wait, if the cells are just swapping hydrogen for potassium, aren't we just treating a symptom? Like, how long until the cell says, I'm full, I can't take any more acid?
Not long at all. The intracellular buffering capacity is finite. That's why you can't just treat the hyperkalemia. You have to fix the underlying acidosis, or the cells will just keep jumping potassium until the heart arrests.
Let's talk about how that arrest happens. The assessment and diagnostics for potassium are entirely focused on the ECG. Let's trace the electrical deterioration of hyperkalemia on a cardiac monitor. What happens first?
Potassium alters how the heart depolarizes and repolarizes. In hyperkalemia, the resting membrane potential becomes less negative. It creeps closer to the threshold. This makes the cardiac cells hyperexcitable at first. Repolarization happens too fast. On ECG, the very first initial finding is tall, peak T waves.
Peak T waves.
Yeah, they look like sharp, narrow tents. They are unmistakable.
And if the potassium keeps rising, if it hits 7 or 8, as the hyperkalemia worsens, cardiac depolarization actually begins to slow down and fail. The atria stop firing properly, so you lose the P wave entirely. The PR interval prolongs. And then the QRS complex, which represents ventricular contraction, begins to widen out. It looks thick and bizarre.
And the final decompensation, the part that kills them.
If you do not intervene when you see that wide QRS, the electrical system completely degrades into a sine wave pattern, which rapidly devolves into ventricular fibrillation or ventricular standstill. The heart just stops beating. Simultaneously, the skeletal muscles, which also rely on potassium, become profoundly weak. This ascending paralysis eventually hits the diaphragm, leading to respiratory arrest alongside the cardiac arrest.
So if hyperkalemia makes the heart electrically chaotic and peaks the T waves, then hypokalemia, low potassium, must do the opposite. Does the electrical system just lose its recoil? Does everything go flat?
Precisely. Hypokalemia impairs repolarization. It prolongs it. The heart struggles to reset itself. On the ECG, you won't see peaked T waves. You will see flattened or inverted T waves. The ST segment will depress. And you will see the classic appearance of a prominent U wave, which is a small positive deflection immediately following the T wave, representing delayed repolarization of the Purkinje fibers.
And physically, what's happening to the patient?
Clinically, the patient will experience severe muscle weakness, debilitating leg cramps, and a weak, irregular pulse.
Okay, we need to talk about the priority nursing actions and the pharmacology for treating hyperkalemia, because this is an incredibly specific sequence. It is a choreographed dance. First, next, then walk us through it.
This sequence saves lives, and you have to do it in the exact right order. First, you must immediately stabilize the cardiac membrane to prevent ventricular fibrillation. You do this by administering IV calcium gluconate or calcium chloride.
Wait, calcium, I'm looking at a potassium problem. Does calcium bind to the potassium and lower it?
No, it does absolutely nothing to the serum potassium level. The potassium will still be 7.5. But the calcium immediately antagonizes the toxic effects of potassium on the cardiac cell membrane. It raises the threshold potential, restoring the normal gradient, which stops the heart from degrading into VFib. It buys you 30 to 60 minutes of safety.
Good to know.
By the way, we prefer calcium gluconate for peripheral IBs because calcium chloride is highly caustic and will cause severe tissue necrosis if it extravasates.
Okay, so first, we stabilize the heart with calcium to buy us time. Next T.
Next T, you have to temporarily shift the potassium out of the blood and back into the cells where it belongs. You administer 5e regular insulin along with a bolus of D50, 50% dextrose.
The D50 is just there so the massive dose of insulin doesn't crash their blood sugar into a hypoglycemic coma, right? But how does the insulin help the potassium?
Insulin is a powerful stimulator of the sodium-potassium pump. When you give 5e insulin, it supercharges the pumps on the cell membranes, and they rapidly pull potassium from the blood back into the intracellular space. The serum potassium drops dramatically. You can also give high-dose nebulized albuterol because beta-2 agonists also stimulate that exact same pump.
But that's a temporary fix, right? Once the insulin wears off, the potassium is just going to leak right back out into the blood.
Exactly. Which brings us to then. Then you actually have to remove the potassium from the body permanently. You excrete it, you administer binding agents like sodium polystyrene sulfonate, which is kyaxylate, or newer agents like Lopilma. These drugs bind to potassium in the gastrointestinal tract and exchange it for sodium, allowing the patient to excrete the potassium in their stool.
What if they need it gone faster?
You can also use loop diuretics like furosemide to force the kidneys to excrete it. And if the patient is in end-stage renal failure and can't make urine, you have to initiate emergent hemodialysis to physically filter it out of the blood.
That is a brilliant pharmacological sequence. Stabilize, shift, excrete. Now, what about treating hypokalemia? The potassium is low, so we just give them more potassium, right? But there is a massive screaming safety alert here regarding Cyv potassium chloride.
Yes. This is perhaps the most important safety rule in all of nursing. Listen carefully. You never, under any circumstances, give potassium chloride via IV push or as a rapid bolus. It is lethal. It will instantly cause cardiac arrest. In fact, rapid 5e push potassium chloride is the exact mechanism used in lethal injections to stop the heart.
That sends a chill down my spine. You're telling me if a nurse gets rushed and pushes this syringe instead of hanging it in a bag, they're the one causing the code blue. So how must it be administered safely?
It must always be heavily diluted in IV fluids and must always be administered on an electronic infusion pump. You can never run it via gravity. The absolute maximum safe rate of infusion for peripheral IV is 10 milliequivalents per hour. You can only go faster, up to 20 millicu per hour, if the patient is in the ICU, has a central line, and is on continuous, uninterrupted ECG monitoring.
And it burns.
Yeah.
Potassium is notorious for causing intense pain at the IV site.
It is highly irritating to the endothelium of the veins. You have to assess the IV site hourly for any signs of phlebitis or infiltration. If an IV potassium infusion infiltrates into the surrounding tissue, it will cause severe tissue necrosis and sloughing. If the patient complains of burning, you can often slow the rate or request an order to dilute it further, but you never just ignore it.
There's one more differential clue here, that the sources mention a very specific medication interaction with hypokalemia, digitalis toxicity.
Yes. If a patient is taking digoxin for heart failure or atrial fibrillation, you have to monitor their potassium obsessively. Digoxin binds to the same site on the sodium-potassium pump that potassium does. If the patient's potassium drops too low, there is less competition for that binding site, and the digoxin binds exponentially more.
So it overdoses them.
It makes the heart muscle hypersensitive to the drug, leading to profound toxicity. You'll see nausea, vomiting, severe bradycardia, and the classic pathognomonic symptom. The patient will start seeing yellow green halos around lights.
Okay, let's do the 5 things for potassium.
Number 1, core patho, alters resting membrane potential, disrupting cardiac conduction. Number 2, key assessment, irregular pulse, muscle weakness, severe ECG changes. Number 3, dangerous complication, ventricular fibrillation and lethal dysrhythmias. Number 4, priority action, place the patient on continuous ECG monitoring. And number 5, important treatment, calcium gluconate to stabilize the heart for high K, or save IV-KCl infusion for low K.
So the clinical picture is a patient with muscle weakness and an irregular pulse heading toward cardiac arrest.
Right. If you see tall peaked T waves and a wide QRS, think hyperkalemia and do prepare IV calcium gluconate immediately. You respect the electrical power of potassium or it will stop the heart in its tracks.
All right, let's move to the next layer of our chemical ecosystem. We've talked about the heart's rhythm. Now let's look at the neuromuscular stabilizers, calcium and magnesium. It's fascinating how these two electrolytes seem to act in absolute tandem. When one is off, the other usually is too.
They are intimately linked. The 80-20 overview here is to think of calcium and magnesium as physiological sedatives for the neuromuscular system. Calcium is essential for bone structure, but in the blood, it controls nerve transmission, muscle contraction, and blood clotting. It is tightly regulated by parathyroid hormone, which pulls calcium from the bones to raise the blood level, and calcitonin, which pushes it back into the bones to lower it.
And magnesium.
Magnesium is the vital cofactor that produces ATP. Without magnesium, the sodium-potassium pump literally cannot function. But in terms of clinical assessment, they both act as the brakes on the nervous system.
So if they act as sedatives, what happens when their levels are too high? Hypercalcemia or hypermagnesemia?
If the levels are too high, the patient is profoundly oversedated. The brakes are slammed on. The threshold potential is raised so high that nerves struggle to fire at all. You will see profound, debilitating muscle weakness. The patient will be extremely lethargic, confused, and their deep tendon reflexes will be diminished or completely absent. The gastrointestinal tract slows to a halt, causing severe constipation. Eventually, the central nervous system depression will lead to a coma.
And if the levels are too low, hypocalcemia or hypomagnesemia?
The sedative is gone. The brakes are completely removed. The neuromuscular system becomes extremely hyperexcitable. The resting membrane potential creeps so close to the threshold that nerves fire action potential spontaneously with almost no stimulus. This leads to a state of sustained muscle contraction that we call tetany.
Let's talk about tetany. How do you assess for this twitchiness at the bedside? The sources detail two classic, highly specific diagnostic signs.
The first is Schwastek's sign. You lightly tap the patient's facial nerve right in front of the earlobe over the masseter muscle. In a normal patient, nothing happens. But if they are hypocalcemic, that light mechanical tap is enough to trigger a massive action potential, and the muscles on that side of the face will visibly twitch, spasm, or pull the lip up into a sneer.
It's literally hyperexcitability. Yeah. And the second test, Trousseau's sign.
Trousseau's sign is even more specific and sensitive. You take a standard blood pressure cuff, place it on the patient's arm, and inflate it above their systolic pressure. You leave it there for about 3 minutes. What you are doing is intentionally inducing a mild, localized ischemia to the ulnar nerve. In a hypocalcemic patient, that ischemia lowers the threshold potential even further. The nerve spontaneously fires, causing the muscles of the hand and fingers to tightly spasm inward into a flexed, claw-like position. It's called a carpal spasm.
That is a brilliant piece of bedside diagnostic physiology. You are literally testing the threshold potential of the nerve by cutting off its blood supply. Now, the sources also touch on phosphate. How does that fit into this picture?
Phosphate has a direct, rigid, inverse relationship with calcium. They are on a seesaw. If one goes up, the other goes down. This is incredibly relevant because phosphate is cleared by the kidneys. In chronic renal failure, the kidneys can't excrete phosphate, so it builds up in the blood, hyperphosphatemia. This massive amount of phosphate binds to the free calcium in the blood, dropping the calcium level. So a patient with high phosphate from renal failure will look exactly like a patient with hypocalcemia. They'll have the twitching, the tetany, the positive Schwastek's and Trousseau's signs.
Okay, let's talk medications and priorities. How do we treat the lows? Tetany.
For severe hypocalcemia, we administer 5-E calcium gluconate. For hypomagnesemia, we administer 5-E magnesium sulfate. But again, there is a massive safety alert here. 5-E magnesium must always be given on an infusion pump, slowly. If you push IV magnesium too fast, you are slamming the body with a massive immediate sedative. You will wipe out their reflexes, paralyze their respiratory muscles, and induce cardiac arrest.
And for the highs, hypercalcemia, the oversedated patient.
Hydration is the cornerstone of treatment. We want them drinking 3,000 to 4,000 milliliters a day, or we blast them with IV normal saline. The goal is to aggressively flush the excess calcium out through the kidneys. We also use specific medications like bisphosphonates drugs like pomedronate or zoledronic acid.
How do bisphosphonates actually lower calcium?
They are fascinating drugs. They are taken up by osteoclasts, the cells in the bone that break down bone tissue and release calcium into the blood. Once inside the osteoclast, the bisphosphonate induces apoptosis. It forces the cell to destroy itself, so the bone stops dissolving and the blood calcium level drops. We can also administer synthetic calcitonin for a more rapid, immediate drop, though it loses its effectiveness after a few days.
What about deterioration? What is the immediate life-threatening threat that kills the patient before we can even get these drugs on board?
With low calcium, the extreme muscle excitability doesn't just affect the arms and the face, it affects the smooth muscle of the vocal cords. The patient can develop laryngeal stridor or sudden laryngeal spasms, which literally clamps the airway completely shut. They will go into immediate respiratory arrest. You can't even bag them because the airway is locked. That is why you must always have emergency intubation and tracheostomy equipment at the bedside of a severely hypocalcemic patient.
And the lethal threat for low magnesium.
Low magnesium triggers a very specific polymorphic ventricular tachycardia called torsades.Acid-Base. The QRS complexes twist around the baseline on the ECG. It is lethal, it causes cardiac arrest, and the only drug that fixes it is IV magnesium pushed during a code.
Okay, 5 things for calcium and magnesium.
Number 1, core patho. Carine and MG act as neuromuscular sedatives. Number 2, key assessment. Shrivostic and trussow signs when low and absent reflexes when high. Number 3, dangerous complication. Laryngeal spasm, respiratory arrest, or torsades. Number 4, priority action. Keep airway equipment nearby and assess deep tendon reflexes. And number 5, important treatment. 4V replacement for lows or fluid flushing for highs.
So if you see carpal spasm when checking BP, you think hypocalcemia or hypomagnesemia, and do notify the provider and prepare 5V replacement.
Exactly. You are anticipating the catastrophic airway compromise or the lethal arrhythmia long before it actually happens.
Okay, we are moving into the absolute core of critical care physiology, the metabolic engine, acid-base balance, and arterial blood gases, or ABGs. All of these electrolytes we just discussed, potassium, calcium, sodium, they are incredibly sensitive to the pH of the blood. If the blood gets too acidic or too basic, the whole ecosystem crashes.
It is the master regulator of the entire human body. The 80-20 overview here is that normal blood pH must be maintained in a razor-thin margin, 7.35 to 7.45. It is slightly alkaline. If you drop below 7.35, you are in a state of acidosis. If you rise above 7.45, you are in a state of alkalosis. And the body will sacrifice almost anything else, including those electrolyte balances, to keep the pH within that tiny window of survival.
And the body has 3 lines of defense to maintain this, right? 3 separate systems that kick in sequentially.
Yes. The first defense is the chemical buffer systems floating in the blood, primarily by carbonate, phosphate, and proteins. They act instantaneously within seconds, binding up excess hydrogen ions or releasing them to fix minor pH shifts. But their capacity is highly limited. They get used up quickly.
So when the buffers are exhausted, the seventh defense kicks in, the lungs.
Exactly. The lungs control carbon dioxide, or CO2. Now, I want you to completely change how you think about CO2. It is not just a waste gas. For the purposes of acid-base balance, CO2 is an acid, a volatile respiratory acid. The lungs respond in minutes to hours. If the blood is too acidic, the respiratory center in the brain commands the lungs to breathe faster and deeper to blow off the acidic CO2. If the blood is too basic, the lungs breathe slower to retain the CO2 and add acid back into the blood.
And the third and final defense.
The kidneys. They control bicarbonate, or HCO3, which is a powerful metabolic base. The kidneys are the ultimate heavy artillery. They take hours to days to fully respond, but they can excrete massive amounts of acid in the urine or manufacture brand new bicarbonate to dump into the blood.
Let's use our intensivist thinking to break down the 4 main pathophysiological states. Let's start with the respiratory side. Respiratory acidosis. What is the trigger?
The trigger is always hypoventilation. The patient is not breathing enough. Maybe they overdosed on opioids and their respiratory drive is suppressed. Maybe they have severe COPD or pneumonia and their alveoli are destroyed. Because they aren't exhaling adequately, they trap CO2 in the blood. The CO2 combines with water to form carbonic acid, and the blood pH plummets below 7.35.
Conversely, respiratory alkalosis.
The trigger is hyperventilation. The patient is breathing way too fast. Maybe they're having a severe panic attack, or they are in the early stages of acute hypoxia, or they have a high fever. They are exhaling so rapidly that they blow off far too much CO2. They lose all their respiratory acid, so the blood becomes excessively basic, and the pH shoots up above 7.45.
What about the metabolic side? Metabolic acidosis. This seems to be the most common and complex one in the ICU.
Metabolic acidosis happens for one of 2 reasons: a massive gain of fixed acid or a profound loss of base. The classic examples of gaining acid are diabetic ketoacidosis, where the liver is churning out toxic ketoacids, or septic shock, where hypoperfusion forces the cells into anaerobic metabolism, churning out lactic acid. The classic example of losing base is severe lower gastrointestinal diarrhea, which literally flushes the bicarbonate stores right out of the gut. In either case, the kidneys are failing to keep up.
Now wait, I want to push back on the body's compensation here, because I remember reading about a very specific breathing pattern associated with metabolic acidosis: Kussmaul respirations.
Yes. When the kidneys fail to clear the metabolic acid, the brain looks to the second line of defense, the lungs. The brainstem senses the plummeting pH and tells the diaphragm, we need to get rid of acid, fast, and the only acid you control is CO2. Breathe.
But if they're taking these incredibly deep, rapid breaths, say 40 times a minute to blow off CO2, aren't we just setting the patient up to fail from respiratory muscle fatigue? How long can the lungs realistically keep that up before they crash too?
That is an incredibly astute observation, and it is exactly what happens in the decompensation phase. Kussmaul respirations are a compensatory mechanism, not a primary respiratory disease. The patient is breathing like they just sprinted a marathon, but they are lying completely still in bed. It is terrifying to watch. And you were right, the diaphragm is a muscle. It will eventually fatigue. When it does, they stop breathing, the CO2 skyrockets, and they suffer a mixed metabolic and respiratory acidosis that is rapidly fatal. You often have to intubate a patient in severe DKA, not because their lungs are failing, but because their respiratory muscles are exhausted from compensating.
That makes total sense. You are taking over the work of breathing so the body can focus on clearing the acid. Okay, the last state, metabolic alkalosis.
This is a loss of metabolic acid or a gain of base. The most common ICU cause is iatrogenic, severe, prolonged vomiting or continuous nasogastric tube suctioning, where we are literally pumping all the hydrochloric acid directly out of the patient's stomach. The blood becomes basic.
Okay, here is where nursing students and even experienced nurses get completely lost in the math. Reading an arterial blood gas, or ABG, it looks like a random string of numbers. How do we quickly diagnose the origin of the problem without needing a calculator? The sources give us this mnemonic, the Rome method.
Rome is brilliant for quick bedside analysis. It stands for respiratory opposite, metabolic equal. It tells you exactly which system is causing the pH imbalance.
Let's walk through a concrete example. We draw an ABG on a lethargic patient. The results come back. pH is 7.32, the PdCO2 is 30, the HCO3 is 18. Walk me through the Rome steps.
Step 1. Always look at the pH first. Normal is 7.35 to 7.45. Our patient is 7.32. That is low. So we immediately know definitively we have an acidosis. We just have to figure out who is to blame.
Okay.
Step 2, look at the other values. Normal CO2 is 35 to 45. Our patient is 30. That's low. Normal HCO3 is 22 to 26. Our patient is 18. That's also low.
Got it.
Step 3, apply Rome. We compare the direction of the pH arrow to the direction of the HCO3 arrow. The pH is low, the arrow points down. The HCO3 is low, the arrow points down. They are moving in the same direction. Equal. Therefore, according to Rome, it is metabolic equal. This is a primary metabolic acidosis.
Okay, what if the pH was low, arrow pointing down, but the CO2 is high, say 55, arrow pointing up?
The arrows are moving in opposite directions, down and up, respiratory opposite. That would instantly tell you it's a primary respiratory acidosis.
That makes it so incredibly clear. But what about compensation? In our metabolic acidosis example, the CO2 is 30, which is abnormally low. Why?
Because the lungs are desperately trying to compensate. The primary problem is metabolic, the low bicarb. The lungs recognize the highly acidic environment and start hyperventilating those Kussmaul respirations to intentionally blow off CO2, which is a respiratory acid, to try and pull the pH back up toward normal.
The pH was still 7.32. It wasn't fixed.
Exactly. Because the pH is still abnormal, we call this partial compensation. The lungs are trying, but they haven't succeeded yet. If the lungs manage to blow off enough CO2 to actually pull the pH back up to, say, 7.36, we would call it full compensation. The pH is normal, but the underlying machinery is running at maximum capacity to keep it there.
There is a massive ICU pearl in the sources regarding metabolic acidosis specifically. The anion gap. What is that, and why does an intensivist care?
When you have a confirmed metabolic acidosis, you must calculate the anion gap to figure out why it's happening. You simply subtract the major measured anions in the blood chloride and bicarb from the major measured dication, which is sodium. A normal gap is roughly 8 to 12 milliequivalents per liter.
So what if the gap is 24?
If the gap is artificially high, it tells you that there's a massive amount of unmeasured toxic acid floating in the blood taking up space. It means your acidosis is caused by an accumulation of acid like lactic acid in sepsis, or ketoacids in DKA, or toxic metabolites from an aspirin overdose.
And if the gap is normal, say 10.
If the gap is normal, there is no toxic acid accumulation. The acidosis is entirely caused by a massive loss of base. The patient is just pooping out all their bicarb from severe diarrhea. It guides your treatment completely. You treat a high anion gap by fixing the perfusion or giving insulin. You treat a normal anion gap by stopping the fluid loss.
Okay, let's do the 5 things for acid base.
Number 1, core pathome. CO2 is a respiratory acid. HCO3 is a metabolic base. Number 2, key assessment. Hypoventilation causes acidosis. Kussmaul respirations are compensation for metabolic acidosis. Number 3, dangerous complication. CNS depression, coma, and secondary hyperkalemia from acidosis. Number 4, priority action. Support the underlying failing system. And number 5, important treatment. correct the root cause, not just the pH.
So if you see a pH of 7.25 and a PECO to a 55, think respiratory acidosis and do improve ventilation or prepare respiratory support.
Precisely. You don't just stare at the pH number, you support the underlying failing system.
Okay, we have identified the fluid shifts, the neurological sodium threats, the cardiac potassium bombs, the neuromuscular calcium tetany, and the metabolic acid-base engine. We know it is wrong. Let's move to the mechanics of the actual fix, procedures and intravenous fluids. Let's start with the pathophysiology of the IV fluids themselves, specifically tonicity, because grabbing the wrong bag of fluid can be instantly lethal.
Tonicity is everything. It dictates exactly where the water will shift due to osmosis once it hits the bloodstream. Isotonic fluids like 0.9% normal saline or lactated ringers have the exact same osmolality or concentration as normal human blood plasma.
So when you infuse a liter of normal saline into a vein, where does the water go?
Nowhere. It stays perfectly put entirely inside the extracellular intravascular space. It expands the volume of the blood vessels without causing any osmotic shifts into or out of the cells. We use isotonic fluids to treat hypovolemic shock, trauma, and dehydration when we just need to fill the tank to restore blood pressure.
What about hypotonic fluids like 0.45% half normal saline?
Hypotonic fluids are less concentrated, less salty than human blood. When you infuse them, they dilute the blood serum. Because the blood is now dilute, osmosis forces the water to move away from the vessels and into the more concentrated intracellular space. We use them to treat hypernatremia, to rehydrate shrunk and dehydrated cells. But the massive risk is that if you give too much, you will cause cerebral edema. The brain cells will swell and herniate.
And the opposite. Hypertonic fluids like that 3% saline we talked about for severe hyponatremia.
These are highly concentrated, intensely salty solutions. When they hit the bloodstream, they massively spike the oncotic pressure of the blood. They act like an incredible vacuum, aggressively pulling water out of the intracellular space and into the vascular space. We use this to intentionally shrink dangerously swollen brain cells in severe hyponatremia or traumatic brain injury.
But the risk there must be massive circulatory overload.
It is profound. You are ripping fluid out of the cells and dumping it into the veins. If the heart cannot handle that sudden, massive increase in volume, it will instantly back up into the lungs and the patient will flash into acute pulmonary edema. They will literally drown in their own fluid. You must constantly monitor their lung sounds and blood pressure when hanging hypertonic solutions.
Now, how do we get these powerful, dangerous fluids and medications into the body safely? Because a tiny little 22-gauge phi in the back of the hand isn't going to cut it for a continuous infusion of 3% saline or concentrated potassium. The sources detail the use of central venous access devices, or CVAs.
Peripheral 5Es are fine for basic hydration or short-term antibiotics, but in the ICU, we need CVADs. These are long, advanced catheters that are threaded through the venous system until the tip rests directly in the lower third of the superior vena cava, right above the junction of the right atrium of the heart.
Why do we need to dump the drugs directly into the heart? That sounds intrinsically dangerous.
Because of the sheer volume and velocity of blood flow. The blood flow in a small arm vein is sluggish. If you infuse a vesicant, a drug that is highly acidic, highly concentrated, or actively destroys tissue, like chemotherapy, vasopressors, or concentrated potassium through a small peripheral vein, it will rapidly irritate the endothelium, burn through the vein wall, and cause localized tissue necrosis. You will destroy the arm.
But in the superior vena cava?
In the superior vena cava, 2 to 3 liters of blood are rushing past the tip of that catheter every single minute. The moment the harsh chemical exits the catheter, it is instantly diluted by a massive volume of blood, rendering it safe for the vessels. We use centrally inserted catheters, or CVCs, placed in the internal jugular or subclavian veins. We use PICC lines, peripherally inserted central catheters, which go in at the bicep but thread all the way to the heart. And we use implanted ports for long-term oncology patients.
But with a direct, open highway straight into the right atrium of the heart, the complications escalate quickly. Let's talk about the most terrifying one detailed in the text, an air embolism. What actually happens if the cap falls off the central line or the tubing disconnects and air gets sucked directly into the heart?
It is an immediate catastrophic life threat. A large bubble of air travels straight down the catheter into the right atrium and then into the right ventricle. The right ventricle tries to pump this air into the pulmonary artery, but air is compressible. It creates a massive airlock. It completely obstructs the outflow tract. Blood cannot get to the lungs to be oxygenated, and it cannot get to the left side of the heart to be pumped to the body.
What does that look like at the bedside?
The patient will suddenly gasp for air. They will grab their chest and complain of sharp, sudden chest pain. Their oxygen saturation will plummet, they will become deeply cyanotic, and their blood pressure will drop to unreadable levels instantly.
What is the immediate, instinctive muscle memory nursing action? Because you don't have time to call a doctor and wait for orders.
First, you immediately clamp the catheter to stop any more air from entering. Next, you grab the patient and physically wrestle them into a very specific position on their left side, with the head of the bed tilted downward. This is the left lateral Trendelenburg position.
Let's explain the physics of that, why that specific awkward position.
Gravity and anatomy. By turning them on their left side, the right atrium and ventricle are rotated upward. By tilting their head down, the apex of the right ventricle becomes the highest point in the chest. Air is lighter than blood, so it rises. The goal is to force that massive air bubble to rise and trap itself harmlessly against the wall of the right ventricle, keeping it away from the pulmonary valve opening. This allows the heavy liquid blood to flow underneath the air bubble and reach the lungs so the patient doesn't die while the body slowly reabsorbs the nitrogen in the air.
That is incredible. You are using positional gravity to manipulate a bubble inside the heart.
Mm-hmm.
Once they're positioned, then you apply high-flow oxygen at 100% and notify the provider emergently, preparing for a code blue.
Exactly. It requires instant, decisive action.
What about a more common, everyday complication, like line occlusion? You walk in, you attach a syringe to flush the central line, and it meets hard resistance. It won't flush.
The golden rule is you never ever force it. If you push hard against a resistance in a central line, you will either blow out and rupture the catheter internally, or worse, you will dislodge a massive fibrin clot that has formed on the tip, shooting it directly into the lungs and causing a lethal pulmonary embolism.
So how do we prevent the occlusion in the first place?
We use the push-pause flushing technique with normal saline. It relies on fluid dynamics.
Push-pause. Explain the physics of that.
If you just push the syringe in one smooth, continuous motion, the saline flows in a straight laminar line through the center of the catheter. It doesn't clean the walls. But with push-pause, you inject 1 to 2 millilifs, pause sharply. Inject 1 to 2 millilifs, pause. This sudden starting and stopping creates violent turbulence inside the lumen of the catheter. The saline swirls aggressively, acting like a chemical scrubbing brush, actively shearing away fibrin, blood buildup, and medication debris from the internal walls of the catheter, keeping it patent.
Okay, synthesizing the procedures and IV mechanics for our 5 things.
Number 1, core patho. Tonicity dictates where the water will shift. Number 2, key assessment. Monitor lung sounds and BP constantly when giving hypertonic fluids. Number 3, dangerous complication, air embolism or pneumothorax from a CV duel. Number 4, priority action, strict sterile technique for CVA dressings. And number 5, important treatment. Use the push-pause flush method to maintain CVA patency.
So if you see sudden shortness of breath and chest pain while a central line is open to the air, think air embolism and do clamp the line, place them in left lateral Trendelenburg, and apply O2.
That is precisely how you master the delivery systems of critical care.
This has been an incredible journey. We've mapped the fluid dynamics, negotiated with the sodium neurologic gatekeeper, respected the potassium cardiac conductor, understood the calcium and magnesium sedatives, decoded the acid-base metabolic engine, and mastered the physical delivery systems. What truly stands out to me, looking back over this entire deep dive into the source material, is that absolutely none of this is isolated memorization.
No, it is a profoundly dynamic, highly interconnected web of survival. You cannot change one variable in this aquarium without altering everything else. If the blood pH drops into severe acidosis, the cells spit out potassium, which alters the electrical rhythm of the heart, which drops the cardiac output, which causes the kidneys to retain sodium and water, which dilutes the calcium. You have to think 3, 4, 5 steps ahead. You are treating a holistic, cascading system, not a single abnormal lab value.
Before we sign off, I want you to leave the listener with a final intensivist thought, something to mull over on their next shift that builds on all this interconnected physiology we've discussed.
Think about this physiological triage. The body is constantly fighting to survive, but it has a hierarchy of needs. It has 2 major priorities when it comes to fluids and electrolytes. It desperately wants to maintain a normal osmolality, a normal sodium concentration to protect the brain cells from swelling or shrinking, and it desperately wants to maintain a normal blood volume to keep the blood pressure up and perfuse the organs.
But what happens in a crisis? What happens if the body is forced to choose between those 2 priorities?
Volume always wins. The body will prioritize normal blood volume over normal osmolality every single time, even to its own detriment. Imagine a patient who is bleeding out from massive trauma. They are in hypovolemic shock. The baroreceptors scream that the tank is empty. The brain will instantly release massive, overwhelming amounts of antidiuretic hormone to force the kidneys to hold on to any free water they can find, completely regardless of the sodium concentration.
Wait, so the body will intentionally retain so much pure water that it severely dilutes the serum sodium. It will intentionally cause profound hyponatremia.
Yes. The body will literally sacrifice the brain to cellular swelling just to keep the intravascular volume high enough to keep the heart pumping for 5 more minutes. It calculates that a swollen, herniating brain is a better option than an instantly stopped heart. The pump is the ultimate priority. I want you to think about how that absolute physiological desperation dictates exactly which IV bag you reach for first when a trauma rolls through the doors. You have to save the pump before you can save the brain.
That is absolutely mind-blowing. The body intentionally sacrifices the brain to save the pump, because without the pump, everything dies anyway. That completely changes how you view a trauma resuscitation. Thank you for walking through this critical care deep dive into the source material with us. To everyone listening, the next time you look at a lab panel, don't just see numbers, see the battle happening inside the cells. Remember to stay curious, connect the pathophysiological dots, and keep thinking like an intensivist.